Perfect. 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 Okay. Welcome, everyone. I think we're going to get started. Welcome to our evening with Claudia Brown, who, as many of you have heard me say, I am very fond of, and I am very excited to share with you. So I'm going to do a formal introduction, but not so formal because some of the words are in French. And as you all know, that's not something I'm comfortable even pretending that I can do. So the way the evening is going to go is that I will introduce Claudia, our presenter for tonight, and then she will give a presentation for 20 minutes or so. And then following her presentation, I'm going to follow up with her about some of the more common things that I may even have referred women to Claudia to discuss with or to seek treatment for, or maybe just some common questions that I find come up a lot, sort of get the word out there about some additional things that Claudia and other pelvic physiotherapists might be able to help with. And then we will open it up to questions from the participants. As you see, the meeting is being recorded because several people asked me if we could do so. This was even before we knew that the Habs were playing tonight. But let's see, one person asked me because she was traveling on a plane. One person had a baby an hour ago or so. So Baruch Hashem, that's a good thing. And she asked me to record. And a few people just had conflicts. And then other people have a Habs game that they need to be watching. So we will record and we will stop the recording when the questions begin so that everyone can feel comfortable to ask questions. And as Shira was mentioning when we got started about a minute ago, that if people want to send a question anonymously or just privately, they can send it either to Claudia herself or to myself or to Shira if you like, and we can present your question if that's more comfortable. So here we go. Claudia Brown is a professor at the Faculty of Medicine at McGill University, and she is an expert in pelvic health. In 2016, she was awarded a very wonderful award that is in French, and I won't say it properly, so I'm not going to say it, but it is an attestation to how outstanding she is in her field of practice. She has contributed to the profession and in the field of pelvic floor physiotherapy in tremendous ways. She works out of a clinic right here in Montreal, and I have referred to her more times at this point, I think, than I can count, which is a wonderful thing. Claudia offers comprehensive treatment for men and women with sexual pain, chronic pelvic pain, bowel and bladder issues related to the pelvic floor, and much, much more. So we are probably only going to scratch the surface tonight of what Claudia has to offer all of us. But as you will soon see, she has not just a very professional nature, but she is warm and she is kind and she makes her clients feel so comfortable. That is always the feedback I get when I've referred someone to Claudia and I speak with them afterwards, and they always tell me how they're so impressed, not just with her professionalism and her ability and her talent and her skill, but also her warmth and how welcoming and comfortable she makes all the different types of patients that she sees. So we are thrilled to have Claudia with us, and I'm excited for all of you to learn from her. So Claudia, take it away. Thank you so much for being here.
Okay, thank you, and thanks for such a wonderful introduction. I feel really happy to have met you, Rifki, and I appreciate the confidence you have in the work I do, and also in general your openness of spirit of knowing of so much more that can be done for the pelvic floor. So I'm very, very happy to be here. I always like to speak to groups of women, especially because there's so many issues that women can have with the pelvic floor disorders. So I put together a little presentation. I'm going to try to keep it to about 20 minutes just to give you an idea of what I do and what pelvic floor physiotherapists do in general. So I'm just going to share my screen here and find that presentation. Okay, so I'm speaking about physiotherapy and women's pelvic health. So my goals for tonight is to be able to explain to you the role of the pelvic floor in those personal activities of our everyday lives, because the pelvic floor is really at the base of the pelvis where a lot of intimate things happen, going to the washroom, having intercourse, and actually even stabilizing our bodies. So the pelvic floor is really important for many different functions. So I'd like to explain that to you. I'm hoping, through the illustration of a couple of case histories, I'm hoping to be able to give you some hints that might be able to help people right away. And so you can also see what I give you as advice tonight isn't enough, then you can see what we could possibly do in physiotherapy. So the pelvic floor muscles are multifunctional. They play an important role at the pelvic outlet. And so that's where you have urinary system, anorectal system, and sexual system. They all converge together. So if you look at this slide here, so this would be a side view, and you see your spine is here, then your sacrum is here. We've sort of removed the pelvis here, the bony part, and you can see inside. And you see this is the pelvic floor. So this is really my area of expertise. And it's underneath the bladder, and it's underneath the vagina, and it's underneath the rectum. So it really takes care of these three orifices, and they're, oh, that's my cat, sorry. And these three orifices have to be able to open and close for the proper functioning. Okay, so that's the pelvic floor. So you would see here the bladder and the urethra, you would see the uterus, and then the vagina, and then the rectum and the anus. And if you look at the pelvic floor, it really is a floor. So it really is supporting everything at the same time. I think I'm going to have to put my cat outside. Just one second. I'm sorry. Typical Zoom events. Okay, so it's really like the floor of the pelvis. So this is a muscle. So if you think of your muscles like your biceps muscle, when it contracts, it's a muscle that can contract and relax. And the pelvic floor also is a muscle, so it can contract and relax. So sometimes it can get weak or it can get loose. And that could be most often the biggest problem is the biggest reason is really because of childbirth. We call it obstetrical trauma, and that can cause stretching and weakness in the pelvic floor. Not all the time, but it can. And if it's weak or loose, you can have urinary problems. So you can have incontinence, urgency, prolapse, which is like descended organs. Anorectal, if it's weak, it can cause incontinence, urgency, and poor control of gas. And it can also decrease sensation during intercourse. So if you look at it here, you can think of this pelvic floor as having to open and close. Okay, so imagine if it's really not able to close very well. What happens is if you cough or sneeze, there's going to be pressure on the bladder, and then this muscle isn't able to close in order to prevent leakage. So a lot of women, if they get weak in the pelvic floor, if they laugh, cough, or sneeze, they can have leakage. If you look at the next space, okay, so the next space is the vagina, and really the pelvic floor is right at the bottom of the vagina, right at the entrance to the vagina. So if it's weak or loose, you might not feel as much during intercourse, or your husband might not feel as much during intercourse. So that could be a problem. Or if it's weak or loose, you could have problems controlling stool, or you could have problems controlling gas. So this is why the muscle is really important. It has to be able to close and open at the right times. So if the muscle is too tight, however, what can happen is there's two problems I usually see. And when I started in this field, it was mostly with people who had a lot of weakness. And then I started treating women with sexual pain. And that's because their muscle's too tight. And often it's because they might be afraid of having intercourse, or they just might have had pain before and the muscle is contracting. So if this muscle gets really tight, then the opening to the vagina can be tight and it can hurt during intercourse. It can also, if it's too tight, it doesn't release enough to allow you to go for urine, or it can cause constipation. So if it's too tight, it can cause problems with holding everything in and not allowing intercourse. And if it's too loose, you can have leakage. So in physiotherapy, what we do is we do a lot of different approaches for this problem, and we can approach problems with education, exercises. We use manual techniques, electrical therapy, biofeedback, insertion techniques. So we have a lot of different tools that we use to help our patients solve their problems. So I thought the easiest way to work on this would be through a case history. So this is a case history. I would like to give you the example of Mrs. S. So she's a 62-year-old woman. She's had 4 vaginal deliveries. And after these vaginal deliveries, she ended up having some weakness in the pelvic floor, and the pelvic floor was also loose. So it's not only that it's weak, that she can't contract at the right time, but when she's just standing there, it's just not holding everything in. So there's a certain laxity or looseness in the pelvic floor. And this was, in her case, is causing her to have stress incontinence. So when she laughs, when she coughs, when she sneezes, she's not able to really contract and prevent the leakage. And what's happened with that is that the bladder is starting to get used to leakage, and the bladder is sort of going out of synchronicity, and she ends up having increased urinary frequency as well. Because when the bladder fills, normally the pelvic floor will contract and tell the bladder, okay, I'm not at a washroom yet, so let's wait. So if the pelvic floor is in good shape, it's always telling the bladder when it's time to go, when it's not time to go. But if it's weak, it doesn't do this job properly, and women can have problems with increased frequency. The problem also is that being 62, she's menopausal, and what happens when you go through menopause is that the muscles aren't able to contract as well. You have dryness, and you have lack of elasticity, which means the muscle isn't as elastic, and it's also lack of contractility, difficulty contracting. So the fact that she's going through menopause this is why her problems are really coming up right now. So the way we look at it is that the damage happened during those deliveries. She was able to handle it at the time, but then as she came through menopause, then her whole situation changed because she didn't have the same contractility in the muscle that was already a little bit damaged from her vaginal delivery. So these are a lot of the problems that she presents with. So what I'd like to tell you is what I would do with this patient. So one big thing we do is we call it education. So it's education, meaning we just give them advice and we counsel our patients. So we tell her, we're going to teach her how to contract her pelvic floor, but she has to do it right before and during the activity. So she says, Claudia, every time I cough, I leak. So then I'll teach her how to contract her pelvic floor. Next time you cough, you're going to squeeze first and then you'll cough, and that will prevent you from leaking. We also suggest dietary modifications because a lot of women will say, I leak too much, I'm not going to drink any water because I have too much. But that's not good, because then the urine becomes concentrated and the bladder just wants to get rid of it. So in that case, we tell them, no, you have to drink water. You have to have nice concentrated urine to give your bladder good exercise. We tell them to decrease caffeine because caffeine affects the bladder by causing it to contract too much. So if you find you're going to the washroom too often, it could be because you're drinking too much coffee, because the coffee goes right onto the bladder muscle and makes it contract, and then makes you have the urge to go. We also want her to avoid constipation, because when you have constipation, the accumulated stool gets in the way because there's not that much room in here. So you're going to have your stool in here, and you're going to have your bladder in here, and then the bladder can expand if it's too full with other things. So we teach our patients, different ideas on how to control constipation. We also will teach you about, we call it cortical inhibition and planning. Okay, so let's say when you were a baby, you didn't have to learn how to go to the washroom. We went in your diaper. All of you who have so many children, you know that they go in their diaper. They don't have to learn how to do that, but they learn how not to go. So what happens is our brain is able to control the bladder. So we teach our patients how to use their brain power, just like different thought processes, to control their bladder. And we teach them how to plan as well their timing to go to the washroom. Instead of going too often or not going often enough, we put them on a schedule to help them to get their bladder onto a more relaxed schedule. We also teach you how to control the urge with the pelvic floor contraction. So when you have the urge to go, if you squeeze your pelvic floor, it will actually send a message to the bladder and calm the bladder. So using the pelvic floor to prevent leakage and to control urge is really what helps a lot. And then we teach you a lot about the timing of the bladder. Like, it's really normal to go about 5 to 8 times a day. So 5 to 8 times means you should be going to the washroom every 2 to 3 hours if you're awake. If you sleep 8 hours a night, then 5 to 8 times a day is working up to every 2 or 3 hours. So if you find you're running to the washroom every hour, it's not good. You want to say, listen, I know my bladder can hold longer. I'm going to wait and see if I can hold 2 hours. And there's a bit of an urban myth that people say, oh, when you feel the urge to go, you better listen to it. It's not good for you. But that's not true. If you're going too often, it's not good. So you want to really try not to go more than 8 times a day. And really, it's not normal to go in the middle of the night. So, that is something that we see also with a lot of, if you start to have too much frequency during the day, then at the nighttime, sometimes that causes a problem. So what we get you to do is what we call a bladder diary, and we get you to write down, how many times you go. We sort of analyze it and say, looks like you go a lot in the morning, must be that coffee. Looks like you're going a lot just before bed. Maybe we should change that bedtime routine. So kind of look at your day and see what's happening and try to help you work out your visits to the washroom. And on the diary, we have you mark down when you have urgencies or leakages. So then from one visit to the next, we can see if you've improved, because sometimes you improve and you don't realize the improvement until you actually compare your diaries. So the other thing we do is we teach you exercises for those pelvic floor muscles. So they're hidden. We don't know where they are. We can't see them. You can see them if you look with a mirror, and you can actually see some movement happening if you do a good contraction. But most people really are not positive if they're contracting properly. So we teach you how to do that. And that's the muscle that stops the flow. Okay. So what you have to do is you have to really pull in the skin. So we have you sitting down first and then trying to just pull your skin up at the anus and the vulva. And we teach you how to find that skin, and you hold tight for 5 seconds, then you relax for 10. Then we teach you how to contract quickly, quick, just to get the muscle in shape, because we have to work slow twitch fibers and fast twitch fibers. We teach you how to improve your endurance in the muscle as well. Sometimes we do what's called biofeedback. So we use a probe that we put inside the vagina, and these two little bands here can read your electrical activity. So when you squeeze, we can see it on the screen. So if we have the probe in, we have you, okay, squeeze and hold and hold and hold and hold and let go. Squeeze and hold and hold and hold and let go. So that way you can see on a screen what's happening, and you can understand more how your muscle's working. So that sensation of urge, sometimes it's too much pressure in the bladder. So just to repeat, you avoid the caffeine, you drink water, and you time your toileting, and you use your brain centers to calm down the bladder. So some people it's distraction, you think about something else, and other people it's logic. Listen, I only went an hour ago. I don't really have to go now. I can wait, So a lot of it is we call it mind over bladder. One thing that we find, you might see that some of you might say, when you get home and you put the key in the door, and just when you get home, that's when you really have to go. And it doesn't make any sense, because the key isn't really putting more urine in your bladder. But there's a real logical reason for that. Sometimes what you'll do is you have to go to the washroom. You might be at the grocery store and you'll say, I'll go when I get home. I'll go when I get home. And then you meet your neighbor just before you get into the house, and you have to go to the washroom. But in the back of your head, you go, I'll go when I get home. I'll go when I get home. So if you do that, as soon as you get home, your brain goes, you're home, you should go. So that's why your key fits in the door, you're home. So what you have to try to say to yourself instead is, I'll go when I'm sitting on my toilet at home. It's a little bit of a longer sentence. You can maybe just have the image of yourself sitting on the toilet, but it really works, because the brain isn't going to say, okay, go now, until this happens. So you actually can program the activity. So this really works quite well. So that was sort of an example of when the pelvic floor is too loose. Okay, so when the pelvic floor is too loose, we need you to contract it and learn how to use it. But we also not only work on the muscle, but also on the brain power as well. If it's too tight, then you can have these consequences I mentioned. You can have difficulty emptying the bladder, difficulty having intercourse, or difficulty emptying the rectum. So constipation. Sometimes you'll go to the washroom and you have to really concentrate to go. And then when you go to have intercourse, you have pain. I mean, there's a lot of different reasons you can have pain during intercourse, but what often happens is once you've had pain once, then your muscle remembers and says, no, that hurt last time. I'm not doing that. And your muscle closes up, and then it hurts even more because it causes more pressure. So what we have to do is say, okay, that hurt last time. Okay, so I have to relax my muscle to give myself more space so that it won't hurt. So you have to go against the normal reaction. So this is the second case history I'd like to show you. It's Mrs. S. She's 23 years old. She was recently married, and she has what's called Vestibulodynia. Vestibule is the entrance to the vagina, and dynia is pain. So she has pain in the entrance. So she starts to try to have intercourse, and it really, really hurts and even burns and stings and feels like somebody's cutting her with a knife. But as soon as they get in, and the movement happens, the pain isn't as bad. So very often it's at the beginning, and it's a sharp burning sensation at the entrance. And this happens a lot. We see, say on the wedding day, and if you didn't have intercourse before the wedding, and you're going to have intercourse on the wedding night, sometimes there's a lot of anxiety. And also you heard stories from all of your friends and your parents or whoever on what could possibly happen. And sometimes what happens is the muscle just gets nervous and closes, and then when you try to have intercourse, it hurts more. So sometimes we actually even counsel women before the wedding, just to make sure that they can relax. We see women all different cultures, and we see women of all different ages and all different social backgrounds. So some women, it's from the very first time they tried to have intercourse. Other women, it's after they had maybe intercourse while they had a urinary tract infection, and that caused pain. They associated the pain with the intercourse, and then the muscle just responded that way. So often what we see is this sort of cycle, like you say you had pain just even once, and then the next time you go to have intercourse, you have this little anxiety thinking, oh no, that's going to hurt. So you tense up, And then that increases the pressure on the entrance to the vagina, and that increases the pain, and that increases the anxiety, and you're kind of in a cycle. So what we do in physio is we try to work on all of these elements of the cycle, work on the anxiety just by explaining, how you can control that. And when you feel in control, it's a lot better. We work on the tension, teaching you how to relax the muscle. We do stretches or elongations for the vestibule, make the vagina more comfortable, and we work on the pain. So this is the type of sort of stretch that we might do. And then we also use accommodators or dilators or trainers. We don't really know what to call them, but we use these, okay? And we can get all different kinds. And the one that we use quite often is this one that you can even buy on the internet. And the thing is that a lot of our patients who have had pain, they just don't want to have the pain, and so they've avoided sex for sometimes 3 months at a time, for 3 months, 4 months. And so in order to get back into it, they have to start gradually. So we teach them how to insert, these trainers of progressive widths until you're ready and it's about the right size. So I know I'm being a little bit graphic here, but that's what we do. And so it can also, this tension, so that's the sexual pain, so it can also cause constipation. So we give our patients advice: eat lots of fruit and fiber, drink water, try to go at the same time each day. And often what we find is a lot of these people who are constipated, instead of relaxing the muscle when they go, they tense up when they try to go, and they try to push and push really too hard. And then what happens is that the harder they push, the more their anus closes. So we teach them what's called an evacuation technique on how to relax the muscle in order to go to the washroom. So it's after a meal. We teach them an intestinal massage. If you have your feet on top of a little bench, like the squatty potty or a small bench, that opens up the anal rectal angle and allows the stool to go out a lot more easily. Teach them to relax the pelvic floor. And what really helps too is the brain, because the brain is always saying, no, no, no. When you were potty trained, you learned how not to go. So your brain is saying, okay, don't go, don't go. Then when you sit on the toilet, your brain is still in the don't go mode. So you have to give it a minute to say, okay, I'm here for a reason. I want to go to the washroom. I'm accepting this. And my brain would allow the muscle to happen. So it's really got a lot to do with the brain. And then we'd get you to take a deep breath, hold 5 seconds, and breathe out. And that makes the diaphragm help to push on the stool and help to evacuate. So we teach that type of technique too. So we get into the urinary system, the sexual system, and also the anal rectal system. So that in a nutshell is what we do. And the thing is about the private parts, it's still full of stigma and taboo. So it's people don't always talk to their doctor about these problems. They don't necessarily discuss them. And it's not something that you're going to mention at a party. Like when I say I'm a physiotherapist, people will be happy to tell me they have a sore back, but they won't tell me that they have pain during intercourse. It's not a subject of discussion. So it's something that's sort of kept taboo. But I think really with the internet now, it's a lot of people are having more information. And I think, now there's a lot of research also in this field. So it's really opening up. And I think I got in 20 minutes there.
That was amazing. Oh my goodness. Claudia, I could listen to you talk for hours.
I can talk for hours, so be careful. I might pull you up on that one.
Okay, thank you so much. I'm just seeing. Okay, I'm good. Everyone can hear me? Okay, perfect. If it's okay, I wanted to just follow up on some of the amazing amount of information that I think we all need to process and digest that Claudia just shared with us.
Okay, sorry.
I wanted to, I need to take notes. So I'm so grateful that we recorded so that I can make sure that I'm going to remember everything that you said. But a couple of things that I think might be of interest to some of the women who have signed on tonight, and maybe the women who will be watching the recording, is if, let's say, a woman notices that she has one of the issues you mentioned, either the incontinence issue, the sexual pain issue, some kind of, or any combination thereof, because sometimes, as you mentioned, these things go together. What's the general, I guess, process that you would recommend a woman go through? Should she go to her gynecologist? Should she reach out right away to a physiotherapist? What would you recommend?
Okay, that's really good question. So a lot of these problems can sometimes just be temporary. So I would suggest that the woman would wait to see if the problem is going to go away on its own. So like, for example, if you start having trouble with urgency and problems controlling urine, it could be that you have a urinary tract infection. So in that case, you would kind of wait and see, and then when you find that you're getting burning to go, then that would be time to go to see a doctor to see if that's what it is. So something like that, when you're getting burning, or if you're getting blood in the urine, like something like that, you'd want to consult a doctor as soon as possible. Other times, looking at the logic. So somebody with the urinary system, if you've had 4 babies and then you've noticed that ever since you had the babies that you were started to have this problem, then it's pretty likely that it could be a problem with stress incontinence. My best case scenario is a patient that comes to me referred by a doctor because I know he's checked to make sure there's nothing else going on. So even my patients with sexual pain, constipated patients, and my urinary patients, I do take them direct access, but I really like to have them screened by doctor first because there's so many things that the doctor can find out that I might not I might not even know about before they come in. So what usually happens is the patients are referred by a doctor, or they're referred by somebody who more or less knows a little bit more about the condition. If I take direct access, because of the internet, I got a lot of women who just come directly. And if I find that it's something that should be looked at, then I'll send them to their doctor. Okay, so it's no problem if you end up coming without the doctor's note. It's no problem if I could tell you if I think you have to see a doctor or not. But so what I would usually, my answer to that question would be to wait it out a little bit and see how it goes. The sexual pain, sometimes it's something that can be fixed with using a little bit of lubricant and relaxing. And also a lot of these things are cyclical. If you notice that you have more problems right before your period or during ovulation, for your incontinence, or even for sexual pain, so you might sort of just see a pattern. So what I would suggest is usually we say maybe about 8 weeks. If the problem's around for about 8 weeks, you should be doing something. If it's urinary and you have blood in the urine and it's really burning, that's when you really should see a doctor. But other than that, you could probably wait 8 weeks and then decide. So we get a lot of patients that do come directly and others doctor to doctor. So I don't know if I answered that.
Yeah, 100%, 100%.
Okay.
What would you say is the typical length of treatment for the challenges you see the most, for the different diagnoses? I know you see women with so many different, um, diagnoses and challenges, symptoms, et cetera. But is there an amount of time that a person should anticipate they will be in the care of a pelvic physio?
Yes, okay. So if it's a problem with sexual pain, okay, typically we might see the patient between 8 and 10 times. The first 4 visits would be weekly, and then afterwards we would spread it out. So typically, if I have a patient that hasn't been having intercourse, say for the last 3 months because she's had too much pain, I usually tell her this whole process should take about 3 months. Because if you think about it, 8 to 10 treatments, but at first they're weekly, but then they're spread out more. So we could say about 3 months for the sexual pain. For patients who have incontinence, that really depends, because if the patient is able to understand her exercises right away, sometimes I might just see her once, give her a program and say, listen, you go do your exercises at home and I'll see you in 6 weeks. So that's very, very variable. If somebody comes to see me and their contraction, they have no idea where their muscle is and they can't find it and they're weak, then in that case, I want to see them every week. So for example, I'm going away on vacation for 3 weeks. And so I have 2 patients today that I don't want to wait. So they're going to see one of my colleagues while I'm gone because they need it every day. So it all depends. So that's very, very variable in terms of the incontinence ones. Constipation patients, it's often advice, see them 2 or 3 times, and then I'll see them sporadically after maybe 3 weeks later, and then maybe 4 weeks later.
That makes sense. That makes a lot of sense. I assumed there was a big, like a broad spectrum for how long people are in therapy. And I know that a lot of the work is done in the clinic, but then a lot more of the work is done at home, with the exercises that you give and the counseling. You can hear in the way that you present your information that you're not just working with the person's body, but your ability to relate to the way women think is so on target. It's excellent.
Okay, yeah, and that's really what I find most fascinating about my work, is really meeting all these women and seeing how they um, take the advice and how they put it into their lifestyle. So I learn from them all the time too.
Oh, that's amazing. Amazing. I had a question that comes up quite often. I I say it in jest, but I think I mean it pretty seriously, that based on everything on my own experience and other women's experiences, would you recommend that all women who've given birth, at least had a, and it's not just vaginal. I think women obviously with C-sections have different challenges, but they certainly, there are a lot of challenges that present themselves post a cesarean delivery. But would you say that it would be helpful to the average woman who's not yet experiencing any of these symptoms, but maybe wants to like get ahead of it, or maybe be proactive before any of this sets in, maybe a couple of years down the road, once she's already given birth once or twice, maybe, would it be helpful for her to see someone proactively?
Absolutely. Actually, in France, the government pays for every woman who's had a baby. They pay for 6 treatments with either a midwife or a pelvic floor physiotherapist. So it's something that's part of daily life for women from France. And yes, absolutely, because there's so many things that we can teach them, and even now some of us are working, even helping women with breast health as well, because it's all part of women's health, but definitely, yeah. So even we see a lot of women now prenatal, so just before they have the baby, so we give them ideas of how to recuperate afterwards and how to prevent pelvic floor problems. So and studies have also shown that if the woman has physiotherapy before she has the baby, she has less likelihood of having incontinence afterwards. So as a preventative measure, even before seeing the baby, we think it's a great idea. We think everybody should. And then postpartum, we think it's a really good idea. Not so soon though, because a lot of women that we see, like they've had their baby and 2 weeks later, they want to come in for physiotherapy. And I mean, if they really want to come, I'll take them. But I usually tell them on the phone, listen, there's so much that's going to change in the first 6 weeks, that if I see you even now and I compare it to, I know it's going to be completely different 6 weeks later. So I would prefer to show the woman before she's gone, because afterwards she's got to take care of the baby, she's got all kinds of things to do. So I would often think, come for the visit before you have the baby. You'll have all of this information, you can get your muscle ready, you know what to do postpartum, and then I'll see you maybe 8 weeks after you have the baby, just to check and see what your exercises are like, if you have a good contraction or not.
Amazing. Okay, so I'm not crazy that I think this would be something that every single woman would benefit from.
Yeah. Oh, for sure.
We're going to keep you so busy, Claudia.
Yeah. No, for sure. And it's something too that when my patients come in and we have a discussion, I find that just the first visit, they're usually really, really happy because they understand more of what's going on. I think there's a lot that we can just, that for me now, it's so matter of fact, because I've seen so many women, but sometimes I'll say something and it'll be a real revelation to some patients. And so they leave like on cloud 9, because they've learned so much, and they're more empowered too. You really, the more they know, the more confident they are.
Right, 100%. I mean, that's a main, I would say, one of the inspirations for making sure that we had the program tonight is to start conversations, because information is power. And there are a lot of women who are lacking information about very basic things, as you mentioned. And even when you said, you're being too graphic, but God forbid you were not being too graphic at all. That's exactly why, that's exactly why we have you here, is because we've been really trying to open up the conversation and let women know that it may not be normal to experience some of these things, but it can be fairly typical, and that there are treatments available, and that there are people here with expertise, and they have, it's so much more accessible than it ever used to be. I have a lot more questions, but I'm starting to see some questions on the chat. So maybe we'll see how the time goes, and I'll start to read some of those if that's okay. And if we have time, I'll add some more at the end. Okay, so the first question someone sent me privately is, what is an Msela chair? Do you know what that is?
An Msela chair?
EM Sela, like EM, one word, and SELA.
COA. It could be, if I'm not sure, but I was at a conference where they do have these chairs that you can sit in, and it gives you sort of a current that can help with the pelvic floor. And I think that might be it. And so women, the way it's sold is that you just have to sit on the chair and it's going to activate your pelvic floor. So you don't have to have any internal, you don't have to take off your clothes, and you can cure your incontinence. I think what it does is it does activate the muscles in a certain extent. Because when I sat on it, I had to really move around to make sure my muscle was contracting. So, but even if you don't get that muscle, like you have to know the muscle to be able to, aim it properly. But even if not, it would activate some circulation and give you some awareness of the area. But I don't think it's something I've never really been that impressed with it personally. But there's the muscle contraction, but there's the timing, and there's strength, there's endurance, there's speed. There's so many things to do if you can learn to use your muscle on your own. But I'm pretty sure that's what that is. I don't know if that participant wants to confirm. It's a chair that they sell for incontinence, right?
Okay, I'll see if she follows up with me. Okay,
Okay.
perfect. Someone had posted about Medicare, the all important question in Quebec.
Yeah. So is it covered? Okay.
Or will it be in the future? Do you foresee that happening?
I'm really excited because I just got back from the Gaspé, so the Gaspé Peninsula. I gave a course there May 2nd and 3rd. So it's a course that now, because of COVID, we do hybrid courses. We give courses to physiotherapists, and so we gave one day on Zoom. And then we had 3 satellites. We had six physios learning in Montreal, 6 in Quebec City, and I had 4 in Gaspé. So I got to go to Gaspé to teach those 4, and then they finished off with another Zoom. But what was most exciting about this course was that there were only 4 women there, and each one was from a hospital. One was from Saint Anne des Monts, one was from Gaspé, Chandler, and Maria. So there's 4 hospitals in the area, and the government paid for these women to take the course. They paid their travel there, and they're opening up a pelvic floor in the 4 major hospitals on the Gaspé Peninsula. So that's like so exciting, because it means women will be able to have it and not have to pay. Right now in Montreal, most of the time you have to pay for physio. You go to a private clinic, but there's more and more hospitals now that are offering it. It's offered at the Jewish General. It's offered at the St. Luke Hospital as well. A lot of times when it's offered at a hospital, they might say we only treat incontinence or we only treat pain, so they only treat a certain amount. But it's coming to the Medicare, but right now it's still private. And I was just on a committee called the INES, which is the Institute National Institute for Excellence in Health. And on that, I was on a board where they're actually looking into unblocking a bunch of funds for women's health in Quebec. So it's really coming. And I'm a private clinic owner, but I'm thrilled about it because I've been teaching for many years, and the more I teach, the more clinics open, the more people do it, but we don't have fewer patients, because the more women find out about it, the more women just realize that they can be treated. So it's a wonderful thing that it can be available. So in time, it's going to be available more in the public sector.
That is so exciting. That's
It is.
great
Yeah,
news.
I'm thrilled about that. I'm just like, I couldn't believe it. And the way it happened was that one girl had taken our course many years ago, and she ended up working at a hospital, and she started treating it in the hospital and opened some funds, and she's retiring. So she said, I'm retiring, and who's going to take? So she started this whole initiative, and then the four hospitals. Yeah.
Amazing. That's
Yeah.
really amazing. Okay, great. There's another question here. Can pelvic PT help with pelvic symphysis distinction in pregnancy?
Yes, actually. Yeah. So what happens is you have when you have the pelvis here. Okay, so when you're pregnant, there's a hormone in your body called relaxin that circulates when you're pregnant. And what it does, it relaxes all of the bones. Okay, so you have bones and joints. So this is in the back. So you have the sacrum here and the ilium here. And in the front, you have the pubic bone. And so when you deliver, those bones have to be able to sort of separate a little bit to allow for the delivery. And what happens is when you're pregnant, you have all this relaxin, and then you have all this weight from the baby. And sometimes what happens, you can get what's called symphysis pubis problems, where this joint here starts to move a little bit more, and it causes quite a bit of sharp pain right up in the front. And so in physio, we teach you how to stabilize and use your muscles instead of depending on that joint. So yeah, it's really an important solution for women, and it's usually at the end of pregnancy, and then sometimes postpartum, and especially if you're nursing, then the relaxant stays in your body for a longer period of time. And so then you still have this sort of looseness in the pelvis, and it could be in the back or it could be in the front. So that's why you see a lot of women who are really pregnant, they get up like this. And I remember before I was pregnant, I used to think, oh, what are they doing? You know, we know you're pregnant. Why do you have to make such a big deal about it? But what it is that they get up like that so they can lock these joints in the back. I realized when I was pregnant that that's what you have to do. You have to squeeze the glutes to lock this so you don't feel like this is all moving around too much. And so it's all because of this relaxing.
Oh, amazing. Okay,
Hmm.
thank you. Kegels. Who's supposed to be doing them? Like, where do they fit into a woman's life? Like, they're sort of, I've seen that some pelvic physios have given programs similar to this, and they'll say, you know, pelvic physio, it's more than just Kegels. So, but let's
Yeah.
not ignore the Kegels also. Like, what role do they play for the average woman who doesn't have a significant diagnosis? But
Okay, yeah. Yeah, so, say Kegels are really important because those are working. All Kegel is Arnold Kegel is the man that discovered these muscles and said that if you contract them, you can improve your sex life because you'll have more pressure for women who are loose, and you can control urine. So Arnold Kegel discovered this, I think, in the 50s. So that's why the exercises are called Kegels. They got a bad reputation for a long time because doctors would basically give the patient an exercise sheet and say, do these. And the patient would go, okay, how do I do those? Right. But if you know how to do Kegels properly, that's what you have to do. So Kegel exercise is really squeezing the pelvic floor and releasing it, squeezing it and releasing it. The difference in physio is that we take the Kegels, but we use them with different ways to do endurance. They will have you squeeze lighter for a long time. Strength will have you squeeze stronger. Speed will have you squeeze quickly. So all those are Kegels, but they're sort of Kegels that are advanced, in that case. The other thing is patients with pain, they have to learn how to relax the muscle. So they have to do, we call them reverse Kegels. You find the muscle and you relax it. So that's what patients with pain, we want them to squeeze, but just a bit to relax. The patients with incontinence, we want them to squeeze hard to close. But yeah, so definitely Kegel exercises are really important.
okay, and would that be something that you would recommend for a woman who's not yet having any significant issues, but would it be something that could help prevent issues from starting down the road?
Yes, especially if there's been childbirth, because often this obstetrical trauma causes a transition phase, like 6 weeks after you have the baby. Sometimes you might have urine leakage and a few problems, but it usually resolves. You're young, you're resilient, and you get better. But that micro trauma that has happened often shows up more at menopause. So that's why it's good to do Kegel exercises all your life, because you might prevent what might happen during menopause. The other thing about Kegel exercise is it gives you awareness of that area of your body. So you'll be able to, feel when, if you're constipated, you'll be able to understand to relax your muscle. You might have more sexual enjoyment as well, because when you do Kegel exercises, it allows you to have orgasms a little bit more easily because the muscle's working better. So Kegels are really good for everything. As long as you're not just contracting and holding, it's got to be contract and relax. That's the important thing. So people who do too many Kegels, they contract too much and they end up having problems. So you have to make sure you have a contraction and a relaxation period between each contraction.
Okay, that's very helpful. Very, very helpful. Kegels are the answer to not having to visit you necessarily when we're a
Yeah,
little.
that's right. Yeah.
Okay. So someone else posted a question. Where does the average person get information about seeing a pelvic physio? Meaning, is this something that OB/GYN physicians are recommending? Would the nurse at the CLSC talk about it? Do they give it, like when a woman delivers? I've never given birth in Canada or Quebec.
Mhm.
So I don't know what kind of information they give you at discharge from the hospital, but is this something that they're trying to encourage women to access?
It depends on the doctor, really, and it depends on the doctor's. Often the doctor's age, to tell you the truth, because the younger doctors have learned it more in the curriculum than the older doctors have, and the old school doctors often think that I'm the doctor and I should decide everything, whereas the younger doctors realize that it's a team that can work, and oh, they'll help with that. I don't have to worry about her because I can send her to physio. You know what I mean? So it depends on the doctor's age, philosophy, and educational background, I would say. So that would mean that the doctor won't always tell you. I mean, it happens to me every single week. I want to write a book about it, is that the patient would say, why didn't my doctor tell me about this? How come? I had a man actually crying in my office not long ago saying, why didn't my doctor, I told him for like 5 years I've had this pain. Why didn't he send me? So very, very often the doctor doesn't think about sending. So it's got to be really up to the person. And so that's why I think another reason pelvic floor physio is so big now is because of the internet. People are talking about it and everything. So people are accessing it. So if you want to find a physio, there we have the OPPQ, the website. It's the professional order. And you just go on the website. They have English and French. And you just have to, it says find a physiotherapist. You just type in your postal code and they'll give you a list of physiotherapists. And on there, you can also pick if you want a physiotherapist who does pelvic floor physio, because not all physiotherapists do it. And some will treat only incontinence, some will treat only pain. So there's a list there of what they treat, and then you can find somebody close to you that way.
Okay, amazing. Okay, I'm going to throw in some of my follow-up questions that I'm really dying to ask. So I hope you'll all learn from something from this as well. You mentioned that for a long time, the majority of patients you were treating was with a muscle laxity problem, right? With incontinence. Then at some point it started to shift, and now you're seeing women who have a tight muscle issue that's causing them pain during intercourse and some of the other things that you mentioned. Do you have any idea? What do you attribute that to? Was it always there and women weren't seeking help? Or do you think it's something new? Like,
Yeah, no, I think what happened was it wasn't really a shift. It's more that another population was added to the mix. So before it was only really known that we can do this for incontinence. And then how it happened with us is that I teach with Marie-Josée Lord. We have a teaching company together, and she was giving a lecture once at the Royal Victoria Hospital and about incontinence. And she was saying, we teach the patients to contract their muscles. She was saying all these things I was saying. And then there was a psychologist in the audience, and she said her name was Sophie Bergeron. She was actually just in the newspaper this week, and she said, Marie-Josée, if you can teach patients to contract the muscle, can you teach them to relax? Because she was a PhD psychologist doing her studies on sexual pain, and she had read that people have tight muscles. And so Marie-Josée said, well, yeah. And then we started these studies with McGill University, and we thought we were the only ones doing that. And then we found out that a lot of people are doing it all around the world. So I think it was just that another population was added. So it wasn't really a shift. So we still have the same number of women, unfortunately, 1 in 4 women who have problems with incontinence. But on top of that, we have our other patients, which is 1 in 5 who have problems with sexual pain. And then, so we started treating female incontinence, then we started treating male incontinence, then we started treating sexual pain, and now we treat children also with evacuation difficulties. So it's really that the patient population, we can do more and more. And like as a physio, that's what we've seen in physiotherapy in general. There's like now physios are treating cancer, they're treating like a heart rate, they're treating all kinds of different things. So the more we learn, the more the population is bigger.
right. No, that definitely makes sense. I would say from the women that I hear from often, there are some women who've always had pain associated with intercourse, unfortunately, like since their very first experience, and they didn't realize that that wasn't normal or that wasn't okay. And as
Right.
it takes, unfortunately, the longer it goes on, the more vicious the cycle gets. The treatment is also more substantial because there's significant, not just, physical challenges, but psychological as well. But there are a lot of women who I've been speaking to who have said that they never had pain before. And it started, just almost out of nowhere. And they can't attribute it to anything specific. Do you see that happening more, or what do you think is the most common cause, I would say, of
Yeah, so that's where we talk about primary dyspareunia was pain during intercourse. So there's primary and there's secondary. So primary are women who've had it since the very first time they ever had intercourse. It was painful. Secondary, it happened like ever since a different event. And there's usually an event. Sometimes it takes a little while to think about what that event is. And it could be something as insignificant as a urinary tract infection. So they had a urinary tract infection, and then they thought it was all done. Then they had intercourse, and when it hurt again, and then they started remembering the pain, and then the muscle problem came. Sometimes I've had some patients, it's ever since they had a big fight with their partner. They had a big fight, and then that night they had intercourse, anyway, but she wasn't really happy about it. So she wasn't really into it and not as lubricated. So there was pain. And so the next time, even though the fight was over, then the pain was there when she had the intercourse, because her muscle was tight. So very often we find it's sometimes a very insignificant incident that causes pain during intercourse, but then it's the memory of the pain in the brain, but also in the muscles, that makes the problem perpetuate itself. And we work a lot with psychologists as well, because there's just like I was talking about Sophie Bergeron. She was just in the newspaper, La Presse, talking about how they can help women who have sexual pain with cognitive behavioral therapy, because sometimes it's got a lot to do with how you respond to the pain and the thought processes. And now in physio, there's in the world in general, there's a lot of science right now behind chronic pain and how chronic pain is perpetuated, and a lot of it has to do with our thought processes and how we respond to the pain. So we work often in together in interdisciplinary with psychologists as well, so that they can approach. And also there's couple issues, right? So if the woman, if the husband doesn't want to hurt her, so he says, no, it's okay, honey, like, we don't have to have intercourse, and then 3 months pass and they haven't had intercourse, and he starts to have issues about it and she feels guilty. And so the psychologist can help them with all those things that as physios, it's really out of our area of expertise. So that's what's really important, is that. And very often I'll get a patient who gets a paper for a psychologist and a paper for a physio. So sometimes I'll say, well, let's do some of this first and then some later. Or if I see that she's really upset, I'll say, well, go see the psychologist first, then, because I find doing both at the same time is really expensive, and it takes a lot on their time. So I think it's nice to do a little bit of one, a little bit of other at the same time.
Right.
And the
So,
other thing too, that I wanted to mention, because you were saying about, expectations, is that the media really gives a skewed vision of what sex should be like. And I find that a lot of it depends on where you learned what sex should be like. I mean, if you've learned it by looking on the internet and watching, porn movies, it's not the same as real life. And so a lot of young people who've learned about sex on the internet, and they expect that they should be able to have intercourse standing up, like as soon as they get in the house. They don't, the preliminaries aren't there in a lot of the movies. And so a lot of times it's just just asking them what their expectations are for sex, and that they don't really have to be able to have intercourse without any preliminaries. They should be able to relax and everything else. So we try to talk to them about that too. But I mean, a lot of that is really not really the expertise of the physio. So when I first started out, I used to never talk about that stuff because I figured it wasn't my expertise, but I realized that I'm there with the patient right on site, so I should be helping them out. So I do discuss these issues with them now, because I find that really important. And then often, we have like a waiver. We get the patient to sign a waiver saying, yes, the psychologist and the physio can talk to each other about me, and then we can discuss and see how we can work on the problem together.
right, that team approach is so helpful. That's
Yeah.
amazing. Thank you. I'm just going to shoot out a couple of questions that I got, and then we'll wrap up here. Are there any difference in symptoms or treatment for men versus women? I assume that's yes, but I'll let you explain. And then the follow-up to that is, do you often help with women or girls, I guess, who struggle with using a tampon?
Yeah, for sure.
I've referred people to you with that, so I know that you deal with that, but why don't you start with?
Yeah, for sure. So the tampon one's an easy one. So that one we work with patients, quite often for teaching them how to do that. And then the thing that we've noticed, that a lot of our women who have sexual pain, if we look back on my questionnaire, is, did you have trouble with tampon usage? And very often it's that woman that maybe didn't know her body as well and had a little bit of tension and anxiety and was worried that she could hurt something if she put the tampon in. So there's a lot of just, teaching the anatomy, showing that you can't hurt anything, and de-dramatizing and showing them how to do it. So what I'll do often is I'll put it in for them, and then I'll have them do it in the clinic. So I set them up with a mirror and help them to do that. So that's that. For the men, yes, we see a lot of men. And for the incontinence, it's usually men who've had a prostatectomy for cancer of the prostate, where they have the prostate removed. And when they remove the prostate, part of the sphincter is destroyed, so they start leaking. So we teach them how to use the muscles instead. And it's not always successful, but it really can help a lot. But it's the results, like scientifically, aren't fantastic, but they help. not as much as with women. With women, the results are a lot better because it's not surgery, it's stretching that caused the problem. And we see a lot of men with pelvic pain. So a lot of men with pain during ejaculation because their muscle's already tight. And when they ejaculate, it tightens even more. And so it really hurts. A lot of cyclists, like we see a lot of men cyclists, they're, rushed and they want to do 125 kilometers today. And they're type A characters and their muscles tense and they have a bicycle seat. And we see a lot of these men with pelvic pain as well. So the approach is still the same modalities like education, exercise, biofeedback, electrical stimulation, manual techniques. So we do, like with the female, we do manual techniques where we put our finger in the vagina and do some stretches of the muscle. And with the men, we go in the back passage to help to release their muscles as well. So it's quite an involved treatment, but the results are really, really great. I mean, when I started in this field, I was really surprised at what good results, because I've been treating necks and backs for 5 years, and then I stumbled upon this, and I had women bringing me balloons and crying until you changed my life, and I was like, wow, this is something else, So then I realized the impact we had. So it's pretty amazing. Yeah.
That is amazing. That is amazing. I think once we feel like we've done a good enough job letting all the women of the world know what's available to them with a pelvic physio, we need to then make it our job to let the men know that this is also available. I'm more concerned about the women, but I think the men deserve to have their challenges addressed also. Okay, just 2 more quick questions. What can one do about frequent bathroom visits during the night?
Okay, during the night. Okay, so it could be different reasons. So if your feet, one of the easy solutions is if you find at the end of the night your ankles are swollen, and then you go to bed, all that water goes into the bladder. So if it's because of that, because that's one of the reasons, what you would do is about 2 hours before you go to bed, you'd elevate your feet so that all of that fluid can go into your bladder and you can go to the washroom before. So that would be one reason. The other one is if you have frequent visits at night, you probably, or very often, you have frequent visits during the day. So often what I do is I work on the daytime frequency where you can concentrate, use the pelvic floor and concentrate on inhibiting the bladder. So often if you work on the daytime frequency, the nighttime frequency will improve as well. Sometimes it has to be investigated because sometimes it could be a problem of diabetes. So it's something you should discuss with your doctor. Other times it could be related to sleep apnea. So there's a link in the science on sleep between sleep apnea and going to the bathroom at night and having urgency. As you get older, it becomes normal to go once per night. Like as you're under 55, you shouldn't really be getting up at night to go to the washroom. But as you get older, it becomes normal once because there's a hormone that circulates in your body that makes you produce less urine at night. And as you get older, you can't metabolize that hormone as well. So that could be another issue. So sometimes you can take there's a spray that you can take for that, but usually that's given to children. What else? Yeah, and the other thing about the nighttime frequency is you should not drink water 2 hours before you go to bed. So if you go to bed at 10, stop drinking water by 7 o'clock, even 7 or 8, so that all that can go out of your body.
Okay, amazing. Thank you. And then last one, someone is asking, is there any medication that can help with incontinence?
Yes, if it's the urge incontinence where you have the urge to go and you don't make it on time and you're going too often, there's medication that can calm the bladder down and let the bladder hold urine more. So they're called antimuscarinics, and there's another medication on the market, the 2 of them that actually calm the bladder down. So that way the bladder will say, okay, I'll hold more. So that's urgency. But for stress incontinence, there's very little. Some medications can be tried to help close the bladder neck, but they don't really work that well. So if you're losing when you laugh, cough, or sneeze, medication usually doesn't help. But if you're losing when you have the urge and you just don't make it on time, then medication can help.
Okay, amazing. That's so helpful. I cannot thank you enough. I have so many other questions. So we're going to have to do a part 2.
I'd be happy
So
to.
there are so many other things that I hear about and learn about, either from women that I've referred to you or, women who will follow up with me after and explain some of the treatment that you've done with them. So I feel like there is still so much more for us to share. So I am looking forward to having part 2 with you and to sharing you again with the women of our community. I am so grateful to you, Claudia. Thank you so much for sharing.
Oh, well, thank you. Thank you very much. I really, I'm happy that you asked me to speak because I really like like to spread the word, and good luck to all of you. And if I can be of any help, you just let me know.
Thank you.
Thanks so much for
Thank
asking me,
you.
Rifki.
Thank you. Thanks for being here,
Hi,
everyone.
Sarah.
Great night.
Okay.
And
Hi,
go,
how are you?
go Habs, go Hawks, go.
Yeah.
And
What's the score? Anybody know?
3-1 for us.
For us.
Yeah.
All right.
wow, amazing. Okay. In my house, there's an Atlanta basketball playoff game on.
Okay.
So we're trying to watch a lot of things at once, but
Thank you.
also, but we have to split the screen. Okay. Have a wonderful
Okay.
night. Everyone.
Bye.
Thank you.
Thank
Bye.
you. Bye-bye.